being here all. I also thank Carlos for inviting me. It's a great opportunity to be here again. Does it work? Yes. And I wait for my presentation, because my challenge is to show you how this system that was presented by Kai works in clinical daily practice. So what we did, and the study is not finished yet, so you have an interim analysis, part of which I also presented in the Leipzig meeting of autoimmunity of this year actually. But I will go through with you what we can see and what we experience. I'm working in a university hospital. That means that it's not a commercial lab where you have huge amount of samples, but the advantage is that we have full access to clinical data. So that is the advantage in the end, where we can analyze whether the results are fitting in with what we find in the clinic. So we already talked about automatic devices, so I'm not going to say much more about that. And the only thing is that at first I was quite reluctant to accept that these kind of systems were able to detect these kind of patterns, until a guy told me that if you can tell me exactly why you think this pattern is this and the other pattern is that, then I can program it. And he compared it with chess computers, because then I first also thought, well, that never goes to work. They can beat me very easily because I can't play chess, but the best chess players now are also beaten by these machines. And here also you have to realize that there is a complexity of what has to be recognized on the chessboard. It's not only the positions that are taken, but it's also the type of thing which is on that position, and whether it's black and white. So it's not even the 170 dimensions that Kai told us, but still it's quite impressive what you have to think of when you analyze these kind of patterns. And there are different companies using different approaches on how to define these patterns. But essentially, and this is from another system, but essentially it's very important to realize how fluorescence looks like as compared to where the nucleus is. And this is for ANCA. So here you can easily see that, of course, the cytoplasmic granular staining surrounding the nuclear lobes is typical for C ANCA, where here you have the surrounding areas around the nucleus, which is typical for a P ANCA. So basically that is an issue to recognize these different patterns. Kai already told us on how the Euro pattern works with all these different dimensions and looking for the 9 closest cells, and then you define what kind of pattern you are most likely dealing with. So I can skip that. So then we come to the study design, and what we intended to do is to analyze all samples that came in our lab for half a year, and then we expect, and that's the size of our lab, to have about 1,000 ANA, 1,000 ANCAs, and about 250 double-stranded DNA. As mentioned, this is an interim analysis, so for ANA at that point we only had about 700. The same was for ANCA. DNA analysis was finished now, so I can tell you a little bit more about that. And then you have to realize that we have 3 levels of data, because we have the data that are given by the computer, the data that are the visual result of the person who is looking at the screen and say, oh, is this computer right or is it wrong? And of course we also have the results of our routine tests for the different assays. And then you can look for negative positive, you can look for titers, and for ANA and ANCA you can also look for patterns and antigens that are associated with this. So if I start with ANA, I said we analyzed in the interim analysis close to 700 samples, and you see that there are quite some good scores for negative negative versus positive positive, and then I only compare the computer result with the visual result, so that's on the same substrate, on the same slides, but the computer takes up quite a lot more positive results than what we saw visually or scored visually. And in the end we had a concordance of about 90% and a relative sensitivity of close to 100% and a relative specificity close to 90%. And this relative sensitivity and specificity is based on the fact that we consider the visual result as right. which is not true, of course, always. The discrepancies that we had, especially the ones that were positive by the computer and negative by the visual results, were partially or reasonably the result because of inconsistent reading by the person behind the computer. And I can show you an example of that. But the thing is that if you look at these spots, the intensity of staining is similar. It's extremely low, and it is similar. And visual reading gave the left one as a negative result and the right one as a positive result. So, because there was time delay in reading these things, people tend to do some different things, depending also on what kind of slide that you see before. If it was a strong positive, you are more easy to say it's negative next one. So, and the computers are much more consistent in these things. Now, if we looked for the patterns, and for the patterns I have to say that this system is able to identify mixed patterns, so it can tell you that it's both homogeneous and speckled. So, and the data are analyzed as such. So you may have more patterns than positive results altogether because you have these mixed patterns. But on the whole, and I don't go into detail here because of time. Oh, sorry. Always trouble with these things. But on the whole, you can see that the sensitivity and the specificity, again, by stating that the visual result is the right one, which may be disputable as mentioned before, but you reach accuracies of about 90% in sensitivity and specificity, which is quite high, and which may be rather the same when you use two different observers. That you have to keep in mind as well, because they are also often giving different results in the end. And Kai already mentioned that, and that is also a good thing, not only of the Euro pattern system, but also of other systems. Several companies have already mentioned that they will accommodate to ICAP, meaning that the ICAP pattern nomenclature will be a kind of default setting into the system. And that's I think, a good thing for ICAP. As far as we are now, Kai already mentioned that we have most of those patterns available. Cytoplasmic is just cytoplasmic, so there's no distinction between these, but you can do that yourself, of course, if you can distinguish the different patterns. The only issue that we still have is the issue of the dense fine speckled, which is not a special entity right now, but we are going to try to analyze in our data set if we can identify these patterns as well and use it in the future as such. So that's the nice thing. If you collaborate with the industry, you also can get forward, I guess. Now, for the anti-double-stranded DNA, for the Clift assay, as I mentioned, we have more final data in this study. We started with 332 samples that were requested for double-stranded DNA in the time frame that we were studying. For 17, we had insufficient material, so we had to exclude them. 5 of them were considered not to be evaluable because of strange things on the slides. So in the end, we had 312 results. These 312 results were coming from 255 patients that were measured once, 18 patients twice, and 7 patients 3 times in the time frame. And at first, in the intermediate analysis, we encountered a problem that we had about 10% of the samples that had overexposure. So there you couldn't analyze. And then, of course, you can do the titration. And if you then find a positive result in the titration, you're confident that you have some double-stranded DNA. But if your titration is negative, you don't know what to do. But in the meantime, again, the system has been adjusted so that if we encounter these kind of figures, that the system takes a low exposure image, which is much easier to analyze. So in the end, we could analyze close to all those samples, except the 5 that I mentioned. And here again, we had very good agreements, except that we had 19 samples that were positive by the system, which was not confirmed by the visual reading. So again, we have relatively high sensitivities and specificities. And if we focus on those 19, and this is just an example, it looked like that many of them did have some staining of cretidia, but a very low percentage of the cretidia were positive, or there was a kind of ring-like staining, and it was not always easy to decide what to do with it. But now we have also the clinical data, so I checked for these 19 patients what kind of clinical data was available, and it appeared that out of these 19, 12 did not have SLE, 2 had a cutaneous SLE, normally not associated with double-stranded DNA, 4 definitely had SLE, and 1 we don't know. The patient has a very pure clinical manifestation, and eventually, because there is no alternative diagnosis, it has been treated for SLE. We also compared this with a routine Clift assay, and again 15 of them were negative, 1 was not evaluable, and 3 were positive. So anyway, the majority of those discrepancies probably are not linked to double-stranded DNA and are not associated with SLE. But of course, in the end, the reader is responsible for giving the right result, not the machine. The 2 which were positive by visual reading and negative by the computer were both from SLE patients, and they only had very low titers, so 1 in 10 and 1 in 20. So you may have some discrepant results there. And the 32 patients that were positive for both assays, 31 of them were SLE patients and not 1 was not. Why it has double-stranded DNA, I don't know. Then for ANCA, the story is a little bit more difficult. Kai already showed you these biochips where you have ethanol-fixed granulocytes, the formalin-fixed granulocytes, and you also have results of PR3 and MPO. And what we encounter here is that we have different definitions. So a kind of ICAP is not existing in ANCA world, although we do have an international consensus from 1999. And there we distinguish a C-ANCA pattern, which is a classical granular cytoplasmic staining. They also distinguish an atypical C-ANCA, but nobody in the world is using this actually, as far as I can understand. Even not expert laboratories are using this. And you may have a P-ANCA with a perinuclear fluorescence, or you may have atypical ANCA, and that is often a combination of C-ANCA and P-ANCA. And the problem is that the Euro pattern is using somewhat different definitions. They do have C-ANCA and P-ANCA, but P-ANCA is defined as being a P-ANCA on ethanol, but a C-ANCA on formalin, so that's quite different. And they are able to distinguish C and P-ANCA in the single well, which is in the consensus an atypical. What do I do now? So these are then the definitions of ELO. So basically you have C-ANCA, which is rather the same, but for P-ANCA it's a difference in interpretation of the formalin fixed slides, and the rest is considered all non-ANCA associated vasculitis ANCA. Complex name in anyway. And to give you some examples of these discrepancies, if you look at these slides, here you can see that there is a perinuclear ANCA on the ethanol, but you also see cytoplasmic staining. If you go to the formalin, you still see some cytoplasmic staining, but you don't know whether it comes from the P or from the C in the ethanol. And if you look very carefully, but you don't see it probably, there is a positive dot at a very low expression of MPO. Just believe me. But anyway, if you have this kind of sample, in the consensus you should consider this as atypical because it's a combination of C and P, while in the Euro pattern this is considered to be C-ANCA and P-ANCA. And in both cases it's MPO positive. The other example is where you have a C-ANCA staining here in the ethanol, which is completely negative in the formalin. But if you look at this C-ANCA, it's basically, this is a atypical. Is it typical, atypical C-ANCA, I have to say. So this is normally not what you find if you have PR3 ANCA. So, but then in the consensus, this is referred to as atypical C-ANCA. As mentioned, nobody is using this. And in the Euro pattern, this is considered to be a non-AAV ANCA because there is no cytoplasmic staining in the formalin. Now, I will tell you after the lunch a little bit more about the multi-center study that we did, but depending on the patterns that you define and how you define it, you will have different results. In this study, we used a lot of ANCA-associated vasculitis samples versus disease controls. And this is an ROC curve where you see that the green line is that your pattern only identified only C ANCA or P ANCA, so no mixed patterns. In this case, it's C ANCA, P ANCA, but also combinations of that, or any reactivity, so also the non-AAV associated ones are included. And what is apparent is that if you enable the system to identify C and P ANCA, you have the best ROC curve, which is the blue line here. So apparently the definitions of Euroimmune in terms of vasculitis are better than the ones that are used in the international consensus. And here you can see that this very much comes together with results that we obtained in this study. In Copenhagen, they only used ethanol-fixed slides, where in Bad Bramstedt, they used also the combination of ethanol and formalin-fixed slides. And you see that Bad Bramstedt and Euroimmune results are much more similar than the ones from Copenhagen. So you do have an advantage if you use the combination. And the advantage I can show you in the next slide. Because on the upper part, you can see a typical PR3 ANCA. And in that case, you see a relatively weak staining on ethanol, but normally the staining is much stronger on formalin. So that increases the sensitivity of the combination of ethanol and formalin. For MPO, it's just the other way around. The typical MPO ANCA has a rather weak staining on formalin, but a very strong staining on MPO. So there you may lose some sensitivity, but you do increase the specificity because you get rid of all the ANCAs that are associated with other inflammatory diseases. To make the story short, analysis of the data that we have thus far is too complicated because of these discrepancies in pattern definitions. So we have to go all over the samples again and reanalyze them and define what we see. So I think we do have some data, but I think it's not fair to show them because it's not a complete story. So to not keep you too long from lunch, I give you the overall conclusions. I think that the system enables a very good discrimination between positive and negative. And what the advantage is that these systems are far more consistent than when you have to do that by your eyes. Because then you are influenced by what you saw before, positive or negative. Either way, you will have different results. And you are not consistent in different runs from day to day, and even not between technicians and all that. For ANA, the system seems to be more sensitive, but here we still have to define what the clinical relevance is of the data. But again, as mentioned, the system is definitely more consistent over time. For double-stranded DNA, we have the final results, and it's clear that there is a very good agreement, although the system is somewhat more sensitive. But of course, that's not a big issue because you still have to look in the end what you see, whether you agree or not. And we have to go into further detail in the ones that were really not consistent, whether we can find something in terms of the titers, in terms of the confidence that the computer is giving in terms of percentage that he is right, that kind of things. And for ANCA, we have to do the study again. At least we don't have to analyze the samples again, but we have to analyze the pictures again to use the same criteria, the same definitions for the different patterns in order to have the right results. And then I have to thank a lot of people from our lab who were doing all this, besides the routine work, because that's always the challenge. And also the people from Euroimmune that helped us. And again, this is a conflict of interest, but it's also partner in crime in the end. Thank you.
Thank you, Dr. Jan. So